So let me get started. Thank you. So welcome to everyone. Good morning. It's a Saturday. This is a clinical neuromuscular update on a Saturday morning. I'm just so grateful to be here and to talk for the Florida Society of Neurology conference. Thank you very much. I am the director for neuromuscular medicine at Advent Health. Advent Health, for those of you that don't know, that was a formerly called Florida Hospital. It's a great program to work at. We have a lot of support for clinical excellence as well as for research excellence. Let's get started. So today I'll be talking about updates in motor neuron diseases and neuropathies, as well as updates in neuromuscular junction disorders and updates in myopathies. I have no relevant financial disclosures. One of the things that our clinic runs on is this concept of humility. We're always learning. We're learning from our patients. We're learning from our past experiences. There's so much we don't know. Due to the time constraints and such a vast amount of material to cover, as well as a diverse audience today, I do open up to email and phone, and we will have a feedback session, question and answer session at 11:30. In case you need any questions or further details. The cases that I'll be discussing, they are summarized and abbreviated due to the time constraints. So the first case is one of my favorite cases. This is a 55-year-old woman. She presented to the Neuromuscular clinic in Iowa, and she complained of shoulder and back pain when walking. And that, you can just imagine how hard it is to decipher, because that's something that we see in our clinic all the time. So this lovely 55-year-old woman came to my clinic, and she was sitting in the clinic, and she had a normal MRI lumbar and cervical spine, a normal MRI brain, normal CK, apparently normal EMG. She had a normal examination as well as a normal muscle biopsy. So one of the things that I wanted to illustrate here was that although there was a normal exam, I spent quite some time looking at her in great detail, and she couldn't raise her arms over her head. And it was not so much because she was having pain, but it was really because she had significant trapezius and pectoralis atrophy. And she eventually developed the scapuloperoneal weakness. She also had some high arches and hammer toes. What was interesting was her grandmother had similar features here with scapuloperoneal atrophy, and her family also had issues, but they were quite variable. So what was difficult in this situation was that she had a variable family history. Despite everybody in the family having an autosomal dominant condition that had a scapuloperoneal syndrome, there was so much variability in severity, in back pain, in the onset, in the reflexes. Some had brisk reflexes, some reflexes were absent. There was variable fasciculations, variable sensory symptoms on the exam, variable pes cavus, and EMG nerve conductions were variable from normal to neuropathy to even myopathy. And they were even variable in the patients themselves. There were variable CK levels, as well as a variable muscle biopsy in the family. Some had myopathic features, neuropathic features, some were even normal, and there was variable dyspnea. So I ended up repeating the EMG, and it was fascinating that it was actually abnormal after the third EMG. And it was really difficult to localize this presentation. I wasn't sure, with scapular wasting, foot drop, waddling gait, inability to climb stairs, pes cavus, and a normal muscle biopsy. It was hard to actually localize this, but the axonal motor neuropathy gave me a huge clue. And so I ended up focusing on a motor neuron localization. So I did a hereditary motor neuron disease panel, and we found a mutation to be a pathogenic VCP mutation, which was seen not only in her, but also in her affected family members. And the family was overjoyed because her son did not have the mutation, and then her grandson obviously did not have it. So they were happy. The reason why this was a very diverse presentation is because the VCP mutation is responsible for diverse cellular activities. So that's why it was so variable. The most important part of this case is to talk about the first trend in neuromuscular medicine is that the future of neuromuscular medicine is genetic testing, in my opinion. Now genetic testing panels are available at lowered cost. There are sequence analysis, deletion and duplication analysis. There's a yield of 46%. And this is what I do frequently in our clinic are these genetic testing panels. There are other genetic tests that you can do. You can do next generation sequencing, and that sequences the entire genome within a day, but it requires expertise, and it can also result in variants of uncertain significance. So those variants are very challenging to handle. You know, my clinic spends a lot of time dealing with those variants. We discuss the uncertain significance, we discuss, you know, family members, we test family members, we test the patient, and sometimes we have to do muscle biopsies. So it becomes a little bit of a challenge. We also do whole exome sequencing, where we can analyze the sequencing of all the protein and nuclear genes in the genome. And the diagnostic utility is about 37%. It's lower than 46%, which we can see in the gene panels. The whole exome sequencing, that will sometimes miss copy number variations such as deletions from Duchenne muscular dystrophy or large FSHD truncations. Sometimes they'll also miss repeat sequences as seen in myotonic dystrophy. Mitochondrial DNA is also included, but in the clinic, it's expensive, so I only do it when clinically indicated. Another form of genetic testing is a chromosomal microarray. It's a molecular genetic test that is used to detect copy number variations, such as deletions or duplications of chromosome material that range from many sizes. These also can be benign, pathogenic, or uncertain significance. But the most important thing is that it actually detects the sort of chromosomal imbalance. And you can see just the big picture concept here, where you can have a little bit of chromosomal imbalance and see if there's any sort of abnormality. And you can see this in this picture. So I don't use chromosomal microarray, but it's something that can be used. One of the most important concepts of this case is that we're moving towards genetic testing, and genetics now are showing to us that we're becoming, we're able to expand genotypes more and phenotypes with the advent of genetic testing. So for example, if you see this Venn diagram from a population that was analyzed in Turkey, you can see here how just even this BCP mutation covers multiple different disease processes, such as frontotemporal dementia and ALS. Things like this, we have a TRPV4 gene in CMT, which can cover the CMT as well as the distal hereditary motor neuropathy. Even the KIP5A mutation you can see here covers hereditary spastic paraplegia and ALS. So these genes are starting to show multiple different phenotypes, and we're learning more about them. So that's what this case is really focusing on. I know it was a hard case with multiple tests that came back negative. It was challenging. It was a diagnostic mystery, but we used genetic testing to help us figure it out. The VCP mutation has been known to cause hereditary inclusion body myopathy, Paget's disease of the bone, frontotemporal dementia, and familial ALS. We're now trying to expand that phenotype. So these new things like CMT type 2 and now a scapuloperoneal syndrome can be added to the clinical manifestations of a VCP mutation. And this is one of my favorite pictures here, is like the wave of the future. We're moving towards genetics and learning more about genetic conditions and expanding the phenotypes. So getting this family tested and understanding this family is helping us understand neuromuscular conditions. That is the wave of the future. And we have to keep an open mind in terms of understanding these genetic conditions. All right, so our big picture from this case one is that our landscape of hereditary neuromuscular conditions is expanding and changing. In the past, we do a phenotype, we get a history and exam, blood work, and EMG. And we moved to a muscle biopsy more readily and then do a single gene analysis because genetic testing is more expensive. Now we're going to do the phenotype, same thing, and actually the history and exam are extremely important as always. But we do, in the appropriate hereditary neuromuscular conditions, we do a genetic testing when appropriate. And the genetic testing is really important. I feel that genetic counselors are helpful, and it takes a lot of time. So genetic testing interpretations are also challenging once you get them. It's great to have a gene mutation that makes sense, like our VCP patient, our patients who have like the regular gene mutations with CMT1A. It makes sense. But sometimes the genetic mutations can come back positive or pathogenic, and it doesn't make sense. So it's important to investigate that and to actually work through these genetic mutations. For example, we had a patient who came in with suspected possible ALS. And because he had long-standing leg weakness since he was a child, we did genetic testing, and we found a pathogenic COL6A2 mutation, which could potentially result in a Bethlehem myopathy. But his presentation didn't make sense. We weren't sure what to do with this pathogenic mutation. So we ended up doing a muscle biopsy. And the muscle biopsy showed a neuropathic process consistent with ALS. But what do we do with this pathogenic mutation? So, and the family was worried, do we do this? Does he have a myopathy or Bethlehem? It was confusing. So we ended up consulting with Dr. Bonneman in the NIH and trying to figure out, what do we do with this mutation? And we realized after a lot of discussion that the mutation was located in a certain area that represented more of an autosomal recessive presentation of the condition, not an autosomal dominant. And the mutation was not necessarily disease-causing in this patient. So the mutations require a lot of workup, thought, and very much attention to detail, whether this is actually a disease-causing or not. When patients do get genetic testing and then they get variants, that also requires a lot of work. That varies on a case-by-case basis, and some patients need a muscle biopsy, some of them get muscle imaging, and if appropriate, we'll get further genetic testing. So genetic testing is great, but it requires a lot of work. All right, so case 2, this is a 60-year-old woman with hereditary sensory and autonomic neuropathy. This is not her foot, but it is an example of how her foot looked like, because she would get these spontaneous ulcers, and not because she had osteomyelitis or an infection, it's just the part of her hereditary condition, and she had amputations of her feet. She had predominantly sensory symptoms. She had the high arches and hammer toes. But she comes to me because she started to develop progressive weakness in her hands and feet acutely over 1 week after infection. We were not sure if it was due to COVID-19. She thought she was exposed, but her testing didn't come back positive. She still thinks she may have been exposed to COVID-19. She continued to have weakness over 2 months, and we were following her very closely. We did, EMG nerve conduction study that showed a mixed axonal and acquired demyelinating features where CSF protein was elevated. So we diagnosed her with CIDP. We treated her with IVIG, but she kept on calling me that her headaches were very severe, disabling for days. So the next step is something that I feel is another trend in our neuromuscular field. And for those that use this quite frequently, and apologies that it may be very basic, but the most important thing was that this subcutaneous IG and Hizentra was very effective in our patient. And when I joined in Orlando last year, I was surprised a lot of my colleagues didn't really know much about subcutaneous IG and Hizentra. You can see how people put it in subcutaneously. So subcutaneous IG or Hizentra can be given as 0.2 grams per kilogram or 0.4 grams per kilogram of a 20% solution every week, or once or twice a week, depending on patient preference. And then it started usually 1 week after the last IVIG dose, because it's more of a maintenance medication. We're maintaining the IG. In terms of side effects, There are local site reactions, but those can get better with time. And in fact, at the end of the PATH study, 88% of patients preferred Hizentra or the subcutaneous IG rather than going back to the IVIG. And I was really pleased that this subcutaneous IG worked in our patient. But if our patient was struggling with CIDP and perhaps a sensory ataxia, there has been a recent paper that said that we should actually check these antibodies, Neurofascin 155 and Contactin 1. That will help us figure out whether we should use rituximab, because rituximab has been found to be helpful in those patients that have those antibodies. Other medications that we can use for CIDP include cyclophosphamide for refractory CIDP, azathioprine, cyclosporin, and methotrexate. I haven't used that in our clinic today, but I know they're there if I need it, especially my patients who don't respond to the typical treatments for CIDP. All right, so case 3 is a 71-year-old gentleman with arm weakness and fasciculations. This gentleman continued to have progressive weakness and fasciculations in his arms over 2 years. His EMG showed fasciculations in all his muscles. There was concern for a motor neuron disease process. In the workup of this gentleman, I did genetic testing per their request, and just trying to be very complete before we diagnose someone with ALS. And what happened during this process, we found these unknown variants in SMN1 and SMN2, and we're actually working up this unknown variant as we speak. So we really don't know what these variants are, but we're looking into them. The reason why I bring it up is because there has been recent advancements in the treatment options for SMA. And so SMA, spinal muscular atrophy, was, devastating, deadly disease in the past, and now we've got new treatments for this disease. We have Spinraza, which is it contains an antisense oligonucleotide, and it controls the mutations caused from chromosome 5q. It binds and targets the RNA and regulates the gene expression, which enhances the amount of functional SMN protein. It's given intrathecally, which is great because it doesn't have to cross the blood-brain barrier. Unfortunately, patients can get a post-LP headache. However, it has improved and maintained strength in a lot of adults and children with SMA. If you, in fact, go on YouTube or research this, you'll see these phenomenal stories of patients doing remarkably well with it. About 11,000 patients have been on the treatment with clinical and safety data for 6 years. The Spinraza is treated with 4 loading doses. The first 3 loading doses should be administered at 14-day intervals, and the 4th loading dose should be administered 30 days after the 3rd dose. And then a maintenance dose should be administered once every 4 months afterwards. And that has been a little concern for my patients. They want to have a maintenance dose more frequent. And I believe they're coming up with clinical trials to address that issue. Let's go ahead to the next SMA treatment. On August 7th of this year, this medication, Evrysdi, was approved by the FDA. It was the same date our hospital was actually going to start the trial for this and give it to our patients on a clinical trial basis. But we got it approved, from the FDA got it approved. And now there's a medication that can be given to our patients with SMA that's oral. And this modulates the SMN2 gene splicing, it binding 2 sites in the SMN2 pre-mRNA. It increases the levels of full-length SMN mRNA protein. So that also will help our patients with SMA. But there's a lot of unknowns. We don't really know all the side effects. They say fever, diarrhea, rash, ulcers of the mouth area, joint pain, and urinary tract infections. In regards to this patient, he has a motor neuron process given his age, and if he's progressing, we're watching him closely. We will be discussing ALS medications with this patient. He also would like to know clinical trials. Almost all of our patients want to know what's going on in the ALS world. And this is just an update on certain meds that have been trialed for ALS. So mesitinib That alters microglial balance by inhibiting tyrosine kinases. It's an oral medication that actually could slow down ALS when combined with riluzole. A study showed that 4.5 milligrams per kilogram of masitinib actually significantly lowered the rate of decline, about 27% at 48 weeks. And those were patients that had a normal progression of ALS, not a rapid progression. So their ALS FRC score was less than 1.1 per month. Neurone is an intrathecal and intramuscular administration of autologous bone marrow stem cells, and that has been shown to be safe and promising. Arimoclomol is a heat shock protein co-inducer, so far considered safe and also promising, and it's also being used for inclusion body myositis as well. One of the things that I thought would be interesting to discuss, just to be really up to date with our advancements in ALS treatments, is there is a new MRI-guided focused ultrasound. And this MRI-guided focused ultrasound can accurately penetrate the blood-brain barrier. It can target drug delivery to the central nervous system, especially the motor cortex in those with ALS. And there was a study that showed that there was a successful blood-brain barrier opening using MR-guided focused ultrasound in 4 ALS patients already studied. The procedure seemed to be well tolerated with a few side effects, something to look out for in the future. All right, case 4. We have a 28-year-old woman with severely uncontrolled antibody-positive refractory myasthenia gravis for 9 years. And the picture of her seems like it was almost yesterday. She was sitting in my clinic with no energy, unable to talk. She could not communicate because every time she would communicate, she would get short of breath. She had double vision. She was being hospitalized every 1 to 2 months for years and had multiple intubations. She had failed CellCept, rituximab, IVIG, prednisone, Imuran. She even failed a thymectomy. So the next step was to put her immediately on Soliris. She got on eculizumab or Soliris. She had taken her 1 year to try to get on this medication, and she had been denied it. So we got her on it, and it was a record time, I think of just a couple of weeks, we got her on this medication. And currently she's doing really well with no more hospitalizations for myasthenia gravis. She's living her life, she's happy and doing very well. Eculizumab, if those who use it frequently, that's wonderful. For those that don't know much about it, it's indicated for acetylcholine receptor antibody positive myasthenia gravis that is refractory to current treatment options. It is the first complement inhibitor to be approved. It's been well tolerated and effective not just in this patient, but in many of my other patients. It is an IV infusion. The dose is about 900 milligrams IV every 7 days for the first 4 weeks, then 1,200 milligrams IV every 14 days. All right, so this is going to be our last case. We have a middle-aged, healthy woman with walking difficulties. So this woman was an athlete as a child. She played golf at a very well-known Division I school on a full scholarship. As a child, she never had leg cramps or breathing difficulties. She never had problems with her heart or even chest pain. She was a middle of the pack runner. She started to develop proximal upper and lower extremity weakness in her 40s. She had difficulty with hiking and picking up objects from the floor. She had no breathing, swallowing, or speech difficulties. And her examination showed mild proximal upper extremity and lower extremity weakness. Her CK level was slightly elevated, at 600, and her EMG nerve conduction study was unrevealing. She was diagnosed with a non-specific myopathy locally, and her local physician told her, go home, there's nothing much you can do, just live your life, because there's not many treatments. But luckily, she was very persistent and kept working hard to try to find her diagnosis. Now, this is a teaching case, so we're going to go through the differential and labs that could have been ordered. So the differential for proximal muscle weakness includes the limb-girdle muscular dystrophies, Duchenne and Becker muscular dystrophies, the hereditary or acquired myopathies, including myotonic dystrophy type 2, congenital muscular dystrophies, and metabolic myopathies, the inflammatory myopathies, as well as Lambert-Eaton myasthenic syndrome. We are going to go through the labs for the inflammatory myopathies, just to go through them and have this as a reference slide for you. So the myositis labs, this was taken from the AAN Continuum in 2019. There are different antibodies that we can check. We'll go through some of them. For the anti-synthetase syndrome, you can check things like anti-Jo1, anti-PL7, anti-PL12, anti-EJ, OJ, KS, ZO, and HA. And those are associated with myositis, interstitial lung disease, rash, arthropathy, fever, and Raynaud's. For necrotizing myopathy, the anti-SRP antibody is associated with a severe muscle weakness and atrophy. Those that have had a suspicion for statin exposure, you can check anti-HMG-CR. For those with dermatomyositis, there's some labs there like anti-Me2. That represents a mild muscle weakness and responds well to immunotherapy. Anti-MDA5 really has no or minimal muscle involvement. Anti-T1F1 gamma is associated with cancer. There's anti-NXP2 associated with a juvenile onset and calcinosis. Anti-SAE associated with late appearing myositis and a good prognosis. The anti-U1 RNP antibodies, those are associated with a mixed connective tissue disease, anti-PMSCL and anti-Q associated with an overlap syndrome. Anti-NT5C1 is associated with inclusion body myositis, and that can have more severe bulbar and respiratory involvement. For those that use MRI, I've been starting to use a lot of MRI, to help with some situations where we're really uncertain. There are two aspects to an MRI. We can look at edema, which is swelling, and that shows that there's an active process, inflammation, necrosis, or we can look at fatty replacement and muscle atrophy, which shows a more chronic process and irreversible damage. When there's edema, that can represent anything like myositis, but also infection, trauma, denervation, radiation, and rhabdomyolysis. So these two things are what we look at, this edema on the MRI or fatty replacement. Although those are non-specific, combining an MRI with a muscle biopsy can improve diagnostic accuracy, especially in those with inflammatory myopathy. So examples of an MRI here, we can show you, although I'm not an expert at MRI of a muscle, just to give you a big picture concept here for the T1 images. Here's a normal MRI, and here is one with IBM. You can see the fatty replacement. And then here is one with STIR, and you can see the edema is bright. So that is something we can use to help us. For MRI muscle patterns, dermatomyositis can show edema of the subcutaneous tissue and fascia. Polymyositis can show diffuse muscle edema. Immune-mediated necrotizing myopathy can show edema, more edema, atrophy, and fat compared to polymyositis and dermatomyositis. Inclusion body myositis will show edema, atrophy, and fat in those muscles affected, such as the anterior thigh, medial gastroc, and forearm flexors. For those that we're looking for inclusion body myositis, there's a Pittsburgh compound B PET inclusion, Pittsburgh compound B and PET scan that can help detect if it's inclusion body myositis. So you can see how this Pittsburgh compound B has more uptake in those with inclusion body myositis compared to those with idiopathic inflammatory myopathy. So those can help with diagnosis. So a follow-up on our patient. Our patient really didn't need any further testing because the trend now is doing genetic testing. So the patient got genetic testing first. And the patient was found to have 2 pathogenic GAA variants, which suggested the patient had late onset Pompe's disease. And the patient was put on Lumizyme, which is a medication that replaces the enzyme acid alpha glucosidase. And she's doing really well. She's been biking around the nation. I called her a couple of weeks ago, and she's just doing wonderfully. So the summary of the updates, case 1 was the VCP mutation. It's not about the VCP mutation, but more about how we're changing the landscape in hereditary neuromuscular conditions. Case 2 is about CIDP and using subcutaneous IG as maintenance therapy when IVIG is not tolerated. We also discussed other treatments for CIDP. Case 3 is about SMA treatment, Spinraza and oral Evrysdi, ALS clinical trials that are also underway. Case 4 is about myasthenia gravis and eculizumab or Soliris, which is effective. Case 5 talks about proximal muscle weakness. We discussed myositis labs and MRI. Here is my clinic, and I just wanted to say thank you. This is our clinical team, our administrative team. We're just so blessed to be part of this team, I am, and to be growing and serving the area of Central Florida and beyond. I wanted to thank the Florida Society of Neurology, Dr. Jacobs, Dr. Garner for allowing me to speak today and for all their support. We discussed, all the stuff that we've been doing in our clinic, and we've been growing so fast. We are proud and really grateful to be able to have patients from more than 22 states across the country. So we're really happy to be serving the nation. So if you have any questions, don't hesitate to call or email me. That's my cell phone, and I know we'll be having a feedback session later this morning. So thank you.
Thank you so much, Dr. Jerath. You really demonstrated how important it is to do more testing, more genetic testing, to refer patients to neuromuscular experts when they have issues because of the new exciting treatment options we have for some rare diseases. I actually put up a poll, and I'd like—
Yeah, I saw that in the middle of my talk. I saw this poll, so I wasn't sure what that was about.
So if all the participants could please answer that. The question is whether or not you routinely order genetic testing in people who have neuromuscular disorders, or and if not, I listed a couple potential barriers to why you might not do that. So go ahead and answer that poll when you're able to, and we'll look at that during the panel discussion.
That's so exciting. I look forward to discussing about it.
Thank you so much.
Thank you. Thanks for having me. I'm just really honored. So, all right, do I need to stop sharing?
Yes. So our next speaker is Alfonso Chiriboga, and he will be discussing the diagnostic and therapeutic approach